I now invite the panelists to come on the stage. Dr. Marc Merven. Dr. Vidya is here. Okay, I already finished introducing you. And Miss Bhargavi, she's a smart and empathetic speech and language pathologist who works with our Chennai Airway team. She does a lot of work with kids with swallowing and speech problems.
Good morning, everybody. At the outset, I would like to thank Chennai Airway team for giving the opportunity and conducting this panel to create the awareness on pediatric dysphagia, and I hope you keep continuing this as the years to come. And congratulations on the successful conference. I welcome our panelists, and she's already done the introduction, so I'll go straight away to the cases. I'm grateful to Dr. Suresh sir and Dr. Nilanjan sir to set the foundation about dysphagia as such, so I don't have to go, because knowing what the previous two talks, you will be able to kind of clinically correlate with the cases as such. So one important point I want to highlight, the importance of pediatric dysphagia is what Dr. Nilanjan sir had mentioned. The last two words in this line is growth and development. That's the most important for pediatric dysphagia, whereas adults, we have already grown and we are well developed. So that's the thing. So most of us at least. So coming to child one, this is to the panelists. This is a 2-year-old, 8-month male who present weight is around 8 kilos, had a history of global development delay, nutritional anemia, failure to thrive, dysmorphism, microcephaly, atopic dermatitis, was referred to the swallowing team for a history of feeding issues reported since starting with the solid feeds. And the concern for the primary care team is poor weight gain and failure to thrive. So start with Dr. Suresh sir. How would you, with this history, I know there is a lot of history we need to take in pediatric dysphagia, but I've just concised it for the panel. How would you approach this patient, sir, from your point of view?
Yeah,
yes, sir.
I earlier told that I am an ENT surgeon. I am an adult ENT surgeon.
Sorry.
I definitely will not have much of an.
So would you
I think definitely what is more interesting here is about microcephaly.
Yes, sir.
Definitely that has a direct impact on the swallow, because we need to look into the cortical centers there, and probably the failure to thrive. All these things, I will definitely want only the help of the swallow physiologist that is there, because nothing else as a surgeon I am going to. So the only thing that I can do is I can have an issue on that. If there is definitely parents are very having a thing, then I will have to only refer.
So
nothing much I can do.
Thank you, sir. So you would take a little bit of history, and would you, and Nilanjan sir, please go ahead.
Absolutely. So since you've mentioned this history of feeding issues, and since starting of solid feeds, so I'm assuming that the child takes in liquid feeds, probably a little better than solid feeds.
Mm-hmm.
So if the first concern, of course, is that the child's nutrition, I would keep the child on a liquid diet at least for the time being, and then of course has as you mentioned rightly, a very very comprehensive history has to be taken. What is the sort of interaction with the caregiver, then what particular problems does the child encounter during feeding. The swallowing evaluation is something which will come way later in this child. Probably, it has to revolve around feeding itself.
Okay. So what I would like to highlight from the two panelists is the importance of a detailed history, because the patient is never going to complain. The parents would say that, and also the primary care provider. And most of them, the primary care physician would just say they have problems swallowing. It may not even differentiate between a swallowing and a feeding disorder. So that we need to keep in mind. We also need to keep in mind all the other multiple syndromes which usually the child presents with. So the child was, one of the common things we do is the non-instrumental evaluation, which Dr. Nilanjan was talking about. We observe the child. So on observation, the child was appeared to be aversive to food, and this is what we talk about. Sir was talking about the anterior gag reflex. When we put in the mouth, the child ends up spitting out and not swallowing it back. So that's that was there. There's no anxiety issues, and the child was behaviorally appropriate. So cognitively, the child is okay and uses words to communicate, and also there is some hoarseness of voice. So Bhargavi, what would your next step would be when you see this kind of findings?
Yeah, so sir, one of the observation part from which we conclude is also one of the thing a feeding therapist does, which is different from the the problem-oriented way of our perspective. So it's more of a perspective change what I am trying to give. So here we are, why behaviorally appropriate, the child has used words to communicate. What this says is the child is cognitively strong. So ideally when a child is cognitively strong and there is no anxiety involved, the child should ideally not be aversive to food, because eating is something innate, like how sir said, and that should not be happening. And there is a coexisting condition of hoarseness of voice. So this gave the this gives a some form of differential diagnosis that this is not just behavioral and this could be something more. So then the referrals to the ENT for the hoarseness of voice and VFSS was done.
So Dr. Mark, would you do any instrumental evaluation?
Yeah, a 2-year-old with hoarseness of voice is very, very unusual. We tend to see them when they're a bit older, when there's kind of screaming toddlers. So I definitely want to see what the larynx looks like in this case.
So in this patient, we don't have the larynx video, but the patient had thick false vocal cords. The true vocal cords were equally mobile and the rest of the airway appeared normal. So then we went ahead and did a fluoroscopic study, because sometimes the 2-year-olds we don't exactly, by doing fees as such, the child should be equally cooperative and also finding the right time to do it. If the child is on medication, they may not be very aware of having a tube down the throat, and they would be fighting the tube also. And the 2-year-old, it is sometimes difficult situation. So a fluoroscopic study showed, I'll just turn on the video, overall delayed swallowing observed at the pharyngeal and esophageal phases with the normal oral phase. And you can see here there's a little bit of residue in the vallicular and the piriform fossa over here at this point, but that cleared with multiple swallows. And in this, in this part you can see there was actually residue in the thoracic part of the esophagus. There's a bit of a stasis there and the delay in transit, and then it goes down to the stomach. So that is the only finding we could see. So basically what we did was we asked for the vocal cords, the larynx appeared normal functionally, kind of structurally okay, maybe that's okay for the child. So we asked for consultations, like as Bhargavi suggested, a gastroenterology consultation, because some of the common things would be reflux. A very severe reflux can also cause problems or regurgitation with the esophageal dysfunction, endocrinologist's opinion, and a geneticist review. And since the patient was able to take some form of diet, we didn't put him on any tubes as such. We just asked him to go ahead with the liquid diet until we come up with a conclusive diagnosis. So would the panelists want to suggest anything else? Would we want to recommend to the primary team or the family?
If the gastroenterologist is having a look, it's as well. Or even if the otologist, otorhinolaryngologist does it, it's fine. But an endoscopic evaluation of the esophagus seems to be forthcoming. Okay. The children, there's a lot of eosinophilic esophagitis which is underreported and you don't really think of it, but then it's a very common problem, especially in preterms, but then in infants. So it's something which needs to be kept in mind always when you have a situation like this.
So this is a diagnosis still in progress. So like Sir said, could be esophageal esophagitis, could be esophageal achalasia, and could be some kind of a metabolic disorder and other things. So the reason for highlighting this particular case was to based on a little bit of this paper, as Dr. Nilanjan also mentioned, there are two investigations we can do. We can either do a FEE study or a video fluoroscopy study. It depends on center to center. It also depends on the status of the child and also the cooperation about the primary team. That's something we have to convince the primary team, look, we need to do this procedure, and sometimes we might have to repeat. So I'll just take a question from Major Prasanna, sir.
Important history, because there is a failure to thrive. Is this child having recurrent upper respiratory infection or lower respiratory infection?
When we saw that there was no history of that, sir, they did not mention.
Because I'm more concerned of aspiration.
Yes, sir.
That's one thing. And if you're doing a barium swallow for a child, if you're thinking about in a failure to thrive child, and you're doing a fluoroscopy with a barium swallow, if you have a barium aspirate, it causes pulmonary granulomas.
Yes, sir.
So it's always better to go with a gastrographin swallow rather than a barium swallow for these patients.
So I think it differs from center to center, because the center we believe is that gastrographin is more, because of the oily consistency, it is more harmful for the respiratory tract. That's one center protocol.
Yeah, this thing.
So if that aspirates, then there's a pneumonitis kind of picture.
Barium swallow as a pneumonitis, whereas a gastrographin swallow does not.
Yes, I take your point, sir. Each center differs, and we usually, when we do a barium swallow, we keep a presence of a pediatrics colleague with us, because if there is any small signs of aspiration, we abandon the procedure. We don't go and push the child or the mother further. So we'll go ahead with the next case. So this is child 2, a 3-month-old male, late preterm with respiratory distress on day 1 of birth. Have identified that she has a large PDA, so they underwent a PDA closure on day 5, and because of that, the recurrent intubation and extubation post PDA closure. And in the PICU, she was diagnosed as having a left diaphragmatic palsy, for which he went again underwent left diaphragmatic plication. So imagine from day 1, he's been having some sort of surgical procedure, and he's been away from his mum in the PICU, and the present respiratory status was on NIV, and he breaks with Brexit high flow nasal cannula. So he was referred from the ICU consultant regarding asking when to start oral trials. So how would we approach this patient, Dr. Suresh sir? Niranjan.
A child who's undergone a PDA closure, diaphragmatic palsy, I would. So this child also has some respiratory issues. I would definitely go in and do a video laryngoscopy first of all, to assess whether there's a vocal cord palsy, a unilateral vocal cord palsy. Children with unilateral vocal cord palsies can also present with respiratory issues. So that is something which needs to be ruled out.
Okay, sir.
If that's fine, then go ahead and do a FEES or a video modified barium swallow, and then and then it's only after that you can start oral feeding trials.
Okay, so what would be your protocol, Dr. Mark?
I fully agree with what was said.
So we go with
Want
the
to
history again.
exclude the cord
vocal cord
palsy.
palsy. Okay. So I think it was open procedure. So
what does the panel think on starting feeds while the kid is still on non-invasive ventilation? Whether do you want to wait till the kid comes out of HDU, or you're happy to initiate that while the kid is in HDU?
I think it would be a decision made generally by the team in the PICU, but I think I would advise to wait until they're off.
So most of the time we end up speaking to the pediatrician who's responsible for the patient. Look, are you okay for us to do even a trial, or even the ICU consultant? So what his opinion matters a lot. Even though we tell them, look, the patient's ready, we go ahead with them.
It's
there's a lot of air that goes in.
Reflux.
One, that, and two is it's very essential to know why there is an NIV requirement in the child. So so the question is whether that's the only reason why an IV is required. Now, if there's something at the laryngopharyngeal level, that is something that needs to be ruled out.
Okay. So Bhargavi, if the instrumental evaluation appeared normal, there's no vocal cord palsy, no center reflux, what will be your thought process?
So I think, like rightly suggested, if it is only to do with so I would start off with starting oral trials with high flow nasal cannula, or and see how and start it as a trial, because again the child is otherwise the child already had some suck swallow breathing innately present, so it was not
Okay. So if the swallow as such is normal, the physiology of the swallow is normal, and you have to keep in mind that the patient's been away from the mother for almost since the day of birth. So there could be an issue with basically a feeding issue or a behavioral issue rather than a structural problem. So when we observed the patient was drowsy, but there were some cues for skin-to-skin contact the patient felt. Could you elaborate on that, Bhargavi?
So again, sir, so for me, I look at what is the strength the child is showing right from infancy. What is the child communicating is what my thought process goes into as a therapist. So the child had breathing changes when the mother was around. When the skin to skin was given, the child was more calm. So I thought this can be taken as a strength and see what happens in 4 days, and during that time counsel the mother to be to show the child as an act to be the child's safe place, and see what that impact has on the child's recovery process.
So would you...
So those were there, sir. So the child had reflexes. So as the swallowing assessment wise, again the child had the anatomical reflexes were there. So then this was the path which.
So the take-home thing is that if the oral pharyngeal motor examination is normal, instrumental examination normal, maybe this could be a feeding or a behavioral issue. And then for this particular child, this is actually Bhargavi's case, so she and Thiru sir's case. They tried the kangaroo mother care method, and specifically putting the child in one particular position because to reduce the reflex and also the surgical scar. You don't want to compress that. And I noticed that when I saw the our Child Trust Hospital's logo, it's very much equivalent to mother care. So that's why the kangaroo mother care kind of behavior. So that's why I put it up. Yeah. So this is the child follow-up on day 4. So Bhargavi, could you go ahead and elaborate on that?
Yeah, so this is actually in PICU with Bala sir's this one. And so during HFNC, I spoke with sir and the team, and the left-sided position was suggested for the post-surgical recovery and also to reduce GERD, which was also suspected in the child. And that way the side lying was also recommended for KMC, and oral trials were started with 2 ml, and there was a good suck swallow reflex, and from there we increased the syringe feed, and from there, because extensive KMC was given, right now the child is trying to breastfeed as well, and the child is on complete bottle feeds.
Yeah. So there is enough literature to suggest that enhancing physical contact with mother increases the patient's the infant's neuroendocrine pathways. So that also could be tried if it's kind of a feeding problem. So you need to keep that into your mind when you deal with such patients. So coming to the child 3, so this is an interesting case. It's a 1.5-year-old female with 10 kilo weight. Father is a construction worker, mother is a homemaker, single child of a non-consanguine marriage born after 13 years of marriage, so this is a precious child. Child had normal developmental milestone until this accident happened. So this is a ferry boat accident which happened in Kerala. The children were playing in the back of the boat and the parents on the front of the boat. And when the accident happened, the parents were saved, but many children drowned in that. And this is one of the child which was actually saved and brought to the nearby hospital. So it's nearly drowned. So the child was brought with a GCS of 4 at the near local hospital, which features a respiratory failure. During the time resuscitation, they had a cardiac arrest for which the child was intubated in the emergency room, resuscitated, then shifted to the PICU, and at the same day had severe respiratory acidosis. And they observed the PICU, and they found slowly the child's sensorium was started to improve after 12 hours of treatment. And the next day, child was extubated with such readings. And on day 3, the child had focal seizures with posturing episodes, so they started on anti-epileptic drugs. EEG confirmed that, and intubate again to secure the airway. They achieved seizure control and anti-cerebral edema measures, and then had an MRI. MRI showed marked generalized supratentorial neuropharyngeal volume loss, and then they observed with the current medication. And again, 3 days later, the MRI showed diffuse diffusion in the bilateral frontoparietal white matter with cerebral edema, and also bilateral parieto-occipital region hyperintensity, which is suspicious of thin subdural hemorrhage. So the diagnosis was post-drowning hypoxic ischemic encephalopathy with the following sequelae. And when the team saw the patient, so these were the findings. The child was nil per oral on purely NG tube feeding, severely dystonic, and it had a opistotonic posturing, and there was no vocalization, on room air, lot of drooling, tone was varying because of the posture, SpO2 because the child was constantly moving It's a bit difficult for us to monitor, and chest auscultation was clear. We could not test whether cervical pooling or the oromotor examination because constantly the child is moving. So this was the situation, and this is how the child encountered. And with talking to the parents, the detailed history, there's a regression on all skills, language, speech, social, motor, and cognitive. There was never a vomiting episode and no secretion color change, which shows the green or yellow or brown secretions. And NG tube was changed weekly because NG tube kept slipping out, the feeding tube. So that's the reason. And they also got discharged with this, and they tried different types of stimulation, which we thought, but nothing worked. And the patient has started to lose weight. So with this situation, regression of milestones, hypoxic ischemic encephalopathy, recurrent seizures controlled by medications, because the anti-epileptic medications also can cause some form of dysphagia, and past history of cardiac arrest. How would you approach this case? I will leave it open to the panel.
This is far from an ENT surgeon's case.
But most of the time they refer to the dysphagia team, do something, try to get because they're off, the patient's off the ICU. Pediatrician seen, child is losing weight. NG tube and feeding. Okay, sir. G tube, gastric peg tube. Okay, sir. That's what. That's what most of the time we think, but we still try to push. So,
this needs to be done. A flexible laryngoscopy needs to be done.
Yes, sir.
Because the whole point here is, in spite of drooling, this child does not have a lot of respiratory issues, lower respiratory issues. So my assumption is that he does not have a lot of pooling of secretions in the pharynx, and nor is he aspirating his own secretions.
Yes,
so probably a benefit of doubt in that sense has to be given, and a video laryngoscopy. So well, of course a GT for long time NGT tubes is definitely a better way to go forward.
Yes,
but then an attempt to give these children oral feeds, especially certain consistencies, is possible.
We
and
give it a try.
Yes, absolutely.
So we were a bit scared by the primary team not to do anything invasive because any vagal stimulation cause a cardiac arrest. So we didn't want to be responsible for that, and the pediatrician is looking at us. So even though we work very well in the team, so we didn't do any fees because out of that only fear. And clinically, sometimes if the child is not vomiting or gagging, we know that the aspiration, there's no pooling of secretion, because unless the child does not have pneumonia, so that's another sign too. So and trying to find a day to do the fluoroscopy also is very difficult, because every time we go, the child is sedated for an MRI, and video fluoroscopy you cannot do on a sedated child. The indication for fluoroscopy, like what Nilanjan sir was saying, because of the dysphagia issues, and we felt that the patient is a good candidate because we cannot do any other testing, and this is the only thing. And this is almost a few weeks after discharge, so we saw the child. Still the child was in the opistotonic posture, so we don't control the child, we don't strap the child down, we just make the child lie down on the side and try to feed with a syringe. And there was
Slightly behind time, Dr. Vidya.
Last case finishing. So there was what we found was there was a lot of aversion and oral folding. You can see that the child was constantly keeping the bolus in the mouth, and we usually give just 1 ml, sir. I sometimes mix it with breast milk. And when we put a pacifier, we could see that the bolus is trying to go back. The child was trying to do the suck swallow. So that's kind of stimulating the nipple. And with the bottle feeding, child improved. You can see the flow of the barium in the esophagus. Sorry, if I touch the screen, the video stops. So there was no aspiration. You could see it going, but it was more of a lot of oral issues and oropharyngeal issues with her.
So probably she would attest to it, but then it's a good idea to give these children with longer spoons so as to ensure that you bypass the oral phase up to a large extent and give directly into the base of tongue, and probably they can do quite well.
Posterior placement, so we do this. So this is the oral stage. Suckling was absent, but it started off with the pacifier. Severe incoordination, aversion present. Patient was trying to spit it out, and residue, but there's no transit posterior, only anterior, and there's some spillage. So pharyngeal stage, multiple absent swallows, no aspiration, but no aspiration penetration. And on stimulation, there was some swallowing. And esophageal stage, no gross abnormality. So we have to put some time. At the same time, keep in mind the amount of radiation the patient has to be exposed to also. So all this has to be kept in mind. So as a team also, you need to be there when you're doing the fluoroscopy. And as the penetration aspiration score was 1, that Dr. Niranjan has actually added. Yes, sir.
Point out that in a neurological patient, this is a single point assessment.
Yes, sir.
Just because you don't have aspiration penetration during this study,
Yes, sir.
doesn't mean that the child
Yes.
will remain the same throughout.
Correct. That's a very good point, because at that point in time, there was no aspiration penetration, and we felt that maybe let's give a trial. So everything is a trial for a child, not a specific thing, but we might have to come back and review. And that's the importance of a pediatric dysphagia board, so which we started in Amrita with the involvement of these people. As we do also involve the pulmonologist, sir, as the opinion basis. So sir is from Amrita. So at present, from the pediatric, we discuss what will be the next step of plan with everybody giving their input. So the child is doing better. This was the initial discussion happened. And sometimes we even tell them how much do we need to try to the anti-epileptic medicine. That way we know that the child can, as the epileptic medicine weans off, we can start the feeding. Otherwise the child is still under the medication. So with the neurologist giving us all the opinions, the dystonia reduced, swallowing, saliva also reduced, and the pediatric dysphagia board recommended we put it forward, and that's when we discussed about the fees. And everybody's consensus was don't do the fees, try the fluoroscopy. So we went with that. And we tried swallow therapy with flavored and blend diets with also liquids. Bhargavi, would you want to give any more points in this? Oromotor tactile stimulation, sir. So there is oromotor stimulation and thermotactile stimulation. Would you want to elaborate on that? We'll finish in 1 minute.
Yeah.
Yes.
We have a term called recreational feeding. When you put an NGD, the swelling in the larynx increases with time.
Yes, sir.
2-3 months, and that causes further
Edema.
dysphagia. If you get the peg and start recreational feeding, there's like some honey or something on the lips, and the child kind of seeks out.
Yes, sir.
You will be surprised by 3 months how much they improve and surprise.
Absolutely. If there's a brainstem injury and you expect a sort of long-term NGT feeds, it's always a better idea. It opens up not only is the larynx, it also opens up the pharynx. The piriform fossa, one of it is blocked by NGT. So once that opens up, there's a higher likelihood of the child feeding it. Plus the swallow itself occasionally causes a lot of pain because of the rubbing against the RT.
Yes,
so
correct.
that's something.
So you keep a threshold for how long you want to keep the retain the NG tube, or else go ahead immediately.
This child is not going to improve.
Yeah. So that's a big problem,
in terms
sir.
of neurological status with brain volume loss.
Yes, sir. When we discuss this to the parents, sometimes the parents are not for PEG. They're like, no. Then how do we go further? So we try multiple scenarios, involve the parents in the pediatric dysphagia board, and try to tell them, everybody, all the doctors try to convince them. Still, there will be no. Oh, sorry, sir.
Thank you, Vidhyadharan. Sasi, welcome. And this is a big topic. It will go on and on and on. The idea of keeping this topic here is to create little bit awareness with the people here.
Yes,
and we have a lot more to discuss. These things can be discussed off dais. Thank you.
So follow up after 1 week, patient was doing better. No cough, no distress, 2 ml on time, 3 hourly gap, bottle feeding, NG tube removed. Weight gain was there, 9.4 kilos. And dystonia started reducing, still under follow up with the pediatrician and pediatric neurologist, and undergoing physiotherapy, no series. So that's what the importance of multidisciplinary approach in pediatrics will be good. This is what we published. This is the most downloaded paper of 2019 in the laryngoscope. So that was a good thing for us also. So that's it. Thank you. So I'd like to thank the Amrita team. Dr. Jayanti Pavitran does a lot of pediatric swallowing for us, and I'm an adjunct faculty, so I'm not there full time anymore. And these are the other speech therapists and swallowing pathologists who help with that. Thank you so much. Thank you.
Thank you.